Hi everybody, my name's Romany and I'm the Immunisation Public Health Nurse at Tropical Public Health Services Cairns, and Nancy is my other half, so we fill that one role. We've also got some people that have telelinked in tonight, just checking that they're online and can hear and that kind of stuff.
Yeah, perfect. Thanks, Romany. It's Alison.
Hey Alison, fabulous. And some people in the Torres Strait.
Yeah, this is Kristen. Can you
hear
me?
Kristen. Yes, fabulous.
I'm not sure who else is on, but
It's Denise from Cuban.
Ah, Denise.
Was it Cuban?
Yes, Cuban.
Welcome.
Jennifer.
Kuranda Community Health.
Miranda, Peter.
Yep.
Terry and Liz and a few others.
Excellent. Okay, if I can just remind you to put everything on mute, that would be fabulous. And if you want to ask a question as we go, please feel free to jump in. That would be great. Technology. So, again, my name is Romany and I'm half the Immunisation Public Health Nurse at Cairns Public Health, and Nancy is the other part. We've also got the wonderful Carly in the front row, who's our Communicable Disease Control Nurse. Juliet, as you know, isn't here tonight. She's off gallivanting around the world somewhere on long service leave, so we're down her and she's very much missed. And we've got Kathy, who is our fabulous data. And a bit later on, Dr. Richard Gare, who'll be doing the presentation on Zika. So to kick off, we're going to have a little talk about the current NIPS. We're going to cover the Schoolbased program. Thank you, Nancy. The Schoolbased program with the addition of the Meningococcal ACWY, the annual Influenza program, which is in full swing, whooping cough for pregnant women, Zostavax Program update, a quick Coldchain review, and some common vaccine errors that we're seeing at the moment. So, playing with the lights here, ladies. I don't know how to do that, Nancy. I think that's all or nothing. So this is the current NIP that everybody should be using, so the National Immunisation Program schedule for Queensland, and it is dated November 2016. With the addition of the 4-valent meningococcal program, we should be expecting a new schedule to be coming out around the June mark when that vaccine becomes in line. So that is when we're expecting the next one to be there. So just making sure that you look at this date when you're checking out who's having what, etc. So basically this is the full schedule and then information on additional programs and eligibility for funded vaccines is usually on the back, and we had some of them printed out in the foyer there if you would like to grab one. It has the column with the brand names or the trade names here. It has all the diseases in the next column. It has the Indigenous schedule here, and then the medically at risk in the purple. Just a quick thought, if you had an Indigenous child that was also Down syndrome, for example, which column do you think you would be following for their childhood additional vaccines? Yeah, so for their hepatitis A, we would be following the Indigenous schedule, but for their pneumococcal, we would be jumping over here into the medical at risk. So they would get the hepatitis A here and here, but they wouldn't get that Prevnar 13. They would get their Prevnar and their pneumococcal vaccine over here as a medically at risk child. So, starting with birth, we have the HBVax2 pediatric given within the first 7 days, and we also have BCG for those that are eligible. There's recently, well, the last 12 months, been supply issues, maybe a bit longer than that actually. And we have an unapproved TGA vaccine, which is a BCG freeze-dried India strain. It can only be prescribed by an authorised prescriber. At present, we have 3 within Cairns and hinterland, and we're waiting on a 4th. It can only be given by a medical officer or an RN who is BCG trained and accredited. And that's about as much as we have to do with that at Public Health. For the rest of info and questions, we would refer you to Trevor and the team here, and you can give them a call on that number if you need. The 2, 4 and 6 month primary course is Influenza Hexa, which covers the 6 diseases: diphtheria, tetanus, pertussis, polio, Haemophilus influenzae type B and hepatitis B. Prevnar 13, which is your pneumococcal, and Rotatec, which covers your rotavirus vaccines. The 2-month vaccinations can be given from 6 weeks of age, and the 4 and 6 month ins need to be given at 4 and 6 calendar months. So you can't give the 2 months at 6 weeks and then just follow on 8 weeks after that. They need to chronologically be 4 calendar months of age. And we need to keep in mind that there needs to be a minimum 2-month gap between doses 2 and 3 of Influenza Hexa, and that's to have the optimal uptake with the hepatitis B component in that vaccine. 12 months comes next, and there we have MMR. There are 2 brands currently in fridges at the moment, MMR2 and Priorix, and also Monitorix. Indigenous children get their first hepatitis A at this point, and medical at-risk kids get their pneumococcal booster. To check who's medical at risk, there's a big list in the handbook, so just make sure you refer there. Prem babies at 12 months also get a bonus hepatitis B, and that's for those bubbies that are born prior to 32 weeks and or weigh less than 2,000 grams. 18 months we have the MMRV, so the measles, mumps, rubella, varicella. And again we have 2 brands, Priorix Tetra and Proquad. And we also have our first diphtheria, tetanus, pertussis booster of Influenza and Tripicel. And at this point we also have the indigenous hepatitis A dose 2. And that needs to be given 6 months apart from the first dose. And they have their Prevnar 13 here. At 4 years, we have the Influenza IPV, so the diphtheria, tetanus, pertussis and polio booster. And for our medical at-risk kiddies, we have our Pneumovax 23. It's important to note that our childhood immunisations are now funded for catch-up up to the age of 10, and that includes the Indigenous schedule. So previously, our Hep A's and things like that, they were only funded for catch-up to the age of 5, and that's now funded until their 10th birthday. The School Immunisation Program, or the SIP, I really don't like that acronym, but that's what they're calling it now, is for Year 7 only this year, and it consists of 3 doses of HPV Gardasil and a Boostrix. And catch-up of this is funded until the end of Year 8. This year is the final year of catch-up of the Year 8 program last year. So you might have some students in Year 9 that are needing to complete that Year 8 program from last year. So it gets a bit complicated, but that will end in December this year. So the meningococcal ACWY, basically in WA they had 5 confirmed cases of the W strain over a 2-month period in small communities within the Goldfields, Kalgoorlie area. So they did a mass vaccination campaign over there, and then that spread out to a statewide program for WA. It then followed across the vaccination program, then followed across the other states, and South Australia, New South Wales, Queensland, and I'm not quite sure of the others at the moment, have all started their own statewide programs. And basically in Queensland during 2016 we had 45 cases. 26 of those were due to strains W and Y, and 17 were due to B. There's a couple of strains in there that weren't able to be typed, but as you can see, the majority of them should be covered by the ACWY vaccine. So it's a very targeted program, and the school program side of things will be Year 10 students. And then once that starts from May, you should be starting to get some stocks into private practice for all persons aged 15 to 19 years. They're expecting that stock to come into supply in May, but probably closer to June, and it will run for a 12-month period until the end of May next year. If you normally provide school-based vaccinations, then you will automatically get some stock of this. If you don't normally order school-based IMS, you'll need to specifically order some of these vaccines if you think you're going to have clients that are going to want to use them. Yep. No. So the school-based program, I don't know if someone wants that, so the others. So sorry, the question was, with the school-based program in Year 10, will they automatically do Year 11 and 12 as well as a school program? Is that right? Yeah. So no, they won't automatically do that. The school-based program doesn't have capacity to capture that kind of a mass vaccination program, so they're going to specifically target the Year 10s, which are considered the most vulnerable group in that age group. It will then be GP practice and other services that will do the catch-up outside of that program.
So the catch-up outside the program is funded?
Yes. Yes. So the catch-up outside that program will be funded. And again, if you if you normally would do some school-based catch-ups, you will automatically get sent vaccine, and otherwise you'll need to request and order it specifically. And it will be funded for anybody in that 15 to 19 age group, and the school-based will only do the Year 10 students. So the National Influenza Program for 2017 is well and truly in full swing. All of the vaccines this year are quadrivalent vaccines, and they contain the same as last year with the addition of a Phuket 2013-like virus. It is funded for pregnant women in any trimester, Indigenous children from 6 months to 5 years, Indigenous people over 15, any person over 65, and any person aged 6 months and over with a medical condition that predisposes them to complications from influenza. So the Commonwealth this year are really trying to put a focus onto pregnant women in any trimester, Indigenous kids, and those with a medical condition that predisposes them to increased complications. So the Commonwealth have put out a lot of resources, like the beautiful purple one here. You can order them through the Immunise Australia website. We've also got quite a few through public health as well. We've got some of the beautiful tealy coloured resources that I don't have on there, but these ones here, also some more Indigenous focused ones. Sorry for those of you that are dialed in. Give us a ring if you haven't seen them and want some information. We can help you with them. So the new thing from this year is that the Commonwealth also wants all vaccinations to be recorded onto the Australian Immunisation Register. So this is really important for everybody that's starting to do flu. For years now, we have told you that VIVAS doesn't want the information. So now AIR does. So Kathy will be speaking about AIR in a little bit. I won't go into detail there, but you need to start thinking about how you're going to send and get this information onto AIR. The other big thing with the flu program this year is before administering it, you need to check you've got the correct vaccine for the person's age, especially when we're talking about the vaccines like Influenza quad here. It cannot be given to those under 18 years of age. So we've already seen a few of those so far this year. It's basically because they don't have enough information around the use in this age group, and it's not licensed for use in that way currently. You've still got the other vaccines on the market. The flu quadri is over here for those under 35 months, and then the flu quadri and the Fluorix tetra for everybody over 3 years. This little guy is very cute. It's a good little flag about checking the age before you're giving a flu shot. So we've had about half a dozen instances of this so far that we're aware of, and I'm sure that there's going to be a few more. So it's just a nice little reminder to stick on your fridge and give you that kind of thing to think about it before you give it. We've also had a couple of instances in those areas where pharmacy has actually dispensed that brand of vaccine, so it's really important that if you're giving a flu shot to somebody under 18 that you're really careful about checking which brand it is, even to the point on one occasion where the patient's label was placed over the warning about not for use in under 18s. So just need to be mindful of that. Pneumococcal. So Pneumovax 23 is our vaccine on the market here. So for medical at risk category A and B, it's funded for Indigenous persons 15 to 49, 2 doses 5 years apart. Now it's not funded for our non-Indigenous, but it's still recommended. So those recommendations are in the handbook, and it's just about whether it's funded or not funded. It's still very much recommended if they're in category A or B that they should be looking at and trying to get a pneumococcal vaccine. For our non-medical at risk, it's for Indigenous persons from 50 years of age and non-Indigenous from 65 years of age. They're funded for a second dose after 5 years if they have a category A or B condition or if they develop it. Now, this young man here is Kevin. He is a 74, maybe 75-year-old chappie now, and we think he's a bit of a spunk for a 74-year-old. He has got diabetes mellitus, and he's had pneumonia twice. He lives in Sydney, metropolitan area, was very well informed about his health and things like that, never been offered pneumococcal vaccine. The national uptake for pneumococcal vaccine is suboptimal. It's about 30% in our 65 to 69-year-old age group. So it's really important to try and think about that, especially in our healthy, population, because, I'm going ahead one instead of my laser. Because, obviously this gentleman's quite fit and healthy, and other than his diabetes, is going about things and had pneumonia twice and not offered the vaccine. Whooping cough for pregnant women. So this program's been going since July 2014, It's free whooping cough vaccine for pregnant women, and it is ongoing. There's been some questions of late about whether that is still a funded program, and it's definitely very much available. The vaccine to use at the moment is ACWY, and it's funded for all pregnant women in each pregnancy in their third trimester, and ultimately and ideally it would be between 28 and 32 weeks of age. And it gives some protection to the infants up to 6 weeks when they're getting their first dose to get their vaccines and antibodies going. The Shingles vaccine, or Zostavax, it was introduced on the schedule in November last year, and it's funded for all adults 70 years of age. It's a single catch-up dose, and it's funded at the moment for all adults 71 to 79 until 2021. The big thing to note with that at the moment is that, unfortunately, there was an administration in a person down south that was immunocompromised, and it possibly resulted in a death in that person. So there's big fact sheets and information at the moment. This is the Queensland Health one. There's also a Immunise Australia one and an ACWY update out there. Very similar information just about some specific examples of immunocompromised persons and what to do there. But the important things is it is contraindicated indicated in persons who are immunocompromised, and don't administer it. If you have a question or any doubt about that, then seek advice from a specialist, or if they have a specialist in their consulting physician, try and speak with them and find out what their thoughts on the matter are. So why vaccine management is important? We have all seen these types of headlines in the news, concerns about measles, outbreaks, all those sorts of things. More recently, on the telly, we saw that it's possible that ineffective vaccines have been given to babies down in Sydney Hospital, and this is why we think that vaccine management and Coldchain is really important. So Coldchain is maintaining the temperature of vaccines during transport and storage, and that begins, that's from 2 degrees to 8 degrees. And that begins at the point of manufacture. In Australia, we only manufacture influenza vaccine. All of our other vaccines are manufactured in Europe and places like that. So they come from Europe into Australia, into central stores, then off to regional areas and our hospitals or our GPs, all that kind of thing, until we get them into the person's arm. So that whole process, they need to stay between 2 and 8 degrees, and basically from the point of manufacture into the person's arm, we want to maintain that as best we can. We also want to decrease the vaccine's exposure to heat, freezing and light. So that means keeping vaccines in their original packaging and making sure that we monitor twice daily temperatures of our vaccine fridges. No jab, no pay. So this is the final year of no jab, no pay. Thank goodness for that, I'm sure most people are saying. So it's for 10 to 19-year-olds, and the funded catch-up ends this year. Those people that have not completed their schedule by the 31st of December will then have to privately purchase their vaccines. So if you've got any clients that are still humming and ahhing, it might be a good idea to suggest that, because the vaccines themselves after that point are not going to be cheap. Some useful resources that you can use for parents that are requiring information are the NCIRS fact sheets, obviously the Handbook, the Myths and Realities, Responding to Arguments Against Immunisation is also a handy one, and the Science of Immunisation, Questions and Answers. That one's a little bit more technical and is often quite handy for those that want a little bit more of the gutsy nuts and bolts of immunology and that kind of stuff. It's really handy for that if you haven't already seen it. All of these are available electronically through the Immunise Australia program, and I think you can still order hard copies of some of them. So, common errors. Things that we've been seeing lately, number one is people giving the wrong vaccine. So it could be something as simple as packaging and our vaccines. So on the schedule and in your fridges at the moment, you have Influenza, Influenza Hexa and Influenza IPV. And other than the colours on the boxes and the names, it's pretty easy to grab the wrong one unless you've got some flags and some checks in place. So some things that we would suggest is how you set up your fridge. It might sound simple. A lot of you might already do it, but having things like 2, 4, 6 months on one shelf, 12 months on the next, 18 months, so on, 4 years, is often enough of a flag to be able to trigger that. The Priorix and the Priorix Tetra, so the MMR and then the one with the varicella component, are also packaged very similarly. There's just a colour variation in their boxes. There's age limitations, so around influenza as well as a few other vaccines. So having things like this little guy, the little bug that highlights quite clearly and gives you a bit of a flag about checking you have the right vaccine is also a good one. And dose order, so giving MMRV as the first dose rather than at 12 months rather than at 18 months. So with these, it's not just a matter of giving the wrong vaccine, it's also having to recall the patient and giving them the right vaccine on many occasions, or adding in the extra antigens that might have been missed if you've given an Influenza instead of an Influenza Hexa, for example. Oh, the MMR kits are so cute. The second one is minimum intervals, so not adhering to the minimum intervals or giving the vaccines too early. So page 50 has the minimum intervals table and it clearly highlights the amount of time between doses and the chronological age given prior to their due age. So it means that you have to revaccinate. It upsets consumers. It also upsets the staff. So just being mindful of those things. Rotavirus vaccine. So giving the Rotatech vaccine outside of the schedule. So we still quite often see dose 1 given prior to 6 weeks of age and after 14 weeks of age. And the other one that we see quite a bit is dose 2 or 3 given after 33 weeks. So for that, we've got the beautiful Rotatech wheel that works like a conception wheel. Line it up with their date of birth, check the dosing, see whether it's in the right time frame. That wheel is also available online and is really quite handy to use. And it's also important to note that if you've got kiddies coming from interstate, there's another brand on the market, and that's Rotavirus, and it's actually a 2-dose schedule, and it's got very different age limits around it. So you'll need to refer to your handbook if you've got, issues with Rotavirus and Rotatech and how to convert that. With Rotatech, the really important thing to note is that it's got the dosing time periods because of the associated increased risk of adverse events, especially interception with this one. That's more prevalent with dose 1s being given early or late, and the risk decreases after that. Number 4 is extra doses. So making sure that we check records when we have people coming in. Checking the patient files, either your own clinic files or the individuals. Looking at ACWY and VIVAS. So over the last 12 months with the no jab, no pay, our electronic databases have gotten a little bit dirty data-wise. So you do need to try and check both ACWY and VIVAS to make sure that you get a clear picture of what the person's had. The extra doses can possibly lead to an increase of adverse events. It depends on what the vaccine is, and it's also a waste of resources, so both your time and money in regards to the vaccine spend and things like that. Expired doses. Again, it's about medication checking. I don't know where we're at with the 5 rights that it used to be. Today, when I Googled it for an image, there's 10 rights, or 6 rights, or 7 rights, or I'm not sure. I got 7 here with the expired date in there, but there's right to refuse and a whole heap more that I've never thought about before in there as well. Oops, I've doubled up on that sentence. When we're giving an expired dose, it also means revaccinating and upset consumers and things like that. The Immunise Australia website. So this is a really, really handy website. If you haven't had a chance to look at it recently, it's had a bit of a makeover and it's really quite user-friendly. So if you go into the immunise.health.gov.au website, it comes up to this page. In here, we've gone on the health professional section, and if you click on the clinical updates section, it comes up to this page. And in chronological order, it has all of the updates going down the page. So if you haven't had a chance to look at it regularly, you can actually go on there and read down the list to see what you might have missed, what's new, all that kind of stuff. So in the last 8 to 6 months, we've probably got the pertussis booster for 18-month-olds, the Zostavax and persons who are immunocompromised, and the seasonal influenza campaign happening there. Any of the new updates produced from the Commonwealth are automatically uploaded onto this page. So it's a really handy one to keep an eye on. And also the handbook can be reached from that page. So instead of going into the clinical updates, one of the tabs directly below it is the link to the handbook, and it's all online. As we probably all do, we're all a little bit in love with our physical handbook Bibles, or at least I know that we are within the public health unit. A lot has changed since it was printed, and there are a lot of updated information in there. So we really need to start making sure that we're checking the online version, even down to simple information like the whooping cough in pregnant women. Our handbook is very outdated in terms of that, and it says a vaccination is recommended every 5 years, but it's now recommended with each pregnancy, and all the juicy nuts and bolts and information around that is in the handbook. So if you're having questions from your patients with regards to that, especially with pregnant mums, sometimes they can be quite concerned about having vaccines while pregnant. The online version is the one to look at. It does have, once you go into the tab, it does have updates on there as well. So you can specifically go in and look at updates for specific chapters. But there's lots of tables, the HIB table's been updated, all that kind of stuff in there as well. So that is my lot. You've been very quiet. Do you have any questions or any other info that you'd like? too much information for a Wednesday evening? Yeah. Mm-hmm. Yes. Yes, you can purchase it privately. So the question was about Zostavax in those outside of the funded age group of 70 to 79, and can you purchase it privately? And yes, you can. From 50.
Continue. Yeah.
Romney?
Okay. So it wasn't stopped for a little while, but now it's starting to get out there. Sorry, was there a question online? No?
You say something about, like, at this moment, about when we came to the 18-month section. Any changes?
Not at that point. There's lots of things happening around vaccine supply at the moment. So they're looking at what brands are available. There's a shortage of hepatitis B vaccine in the private market, but that's not happening with our funded vaccines at present. So there's nothing that we can kind of pinpoint at the moment. The only thing we would be thinking about is maybe the rotavirus, but we're not sure.
Rodney?
Yeah?
Just what's the consensus about revaccination for flu vaccine, seeing that they're saying it's only lasting 3 to 6 months, with especially the chronic.
Sorry, I can't hear you. Can you just...
What's happening with the influenza vaccine when they're saying that it's only lasting for about 3 to 4 months? Are we going to revaccinate chronic disease clients?
Fantastic. Dr. Gare? Basically, I believe a lot of the information about that waning is more in the elderly population, and it's one of the main reasons that the vaccine supplies were delayed until mid-April, and it's really about targeting that age group. Is that not?
Should we be revaccinating then?
The information out of ACWY is not about revaccinating at present. It's about having targeted programs in those in that elderly age group. Up here in far north Queensland, we don't tend to have such a seasonal influenza time period. So have you got a microphone, Richard?
Yeah, I mean, what they're saying is that firstly, the flu vaccine's less effective in the elderly age group anyway, but also there's good evidence that the immunity doesn't last very long. So down south in temperate areas, we see a peak later in the year, in the autumn and the winter. But up here we get that peak, but we also get an early peak around February, March. So it's a little bit of less of an issue up here. But the point that's being made by some people is that immunisation for the elderly group should be delayed until closer to the peak of transmission. So rather than giving it right at the beginning when the vaccine first becomes available, maybe wait and give it a couple of months later. But as I say, it's less relevant here because we get an early peak in the year anyway. On the issue of revaccinating, as you say, I don't think there's been any guidance on that.
I also forgot to mention as a flag, not funded but very much important, is for those healthy individuals that are travelling. Depending on what areas they're travelling to, there might be influenza outbreaks there and to flag that vaccine as a very easy and affordable thing to use for prevention in that. Yep.
Meningococcal B cases that have happened, are they looking at providing a funded vaccine?
Very interesting question. I believe it's a bit about how much money is in the bucket for the vaccination program. Currently, the Commonwealth are not funding the 4-valent program. The states are having to fund that themselves. So I'm not sure that B will be coming online in the near future, no. Anything else, or happy? Yes. Oh,
Happy. Thanks, Romany.
No problem. Oops, just one.
Okay, the vaccine itself, for that age group we're talking about, 70 to 79, the efficacy is more for the post-herpetic neuralgia, and it's 68%. But for over 60-year-olds, for shingles itself, it's 51%. But the idea where the government saw that there was a benefit was that preventing people from getting that horrible pain that you get with the post-herpetic neuralgia. Okay.
Any others, or everyone's happy? All right. If you have any questions afterwards, please feel free to come and chase us up. We're all a pretty friendly bunch, so yeah.
Thank you. Just put your hands together for Romany. That was excellent. Okay, our second speaker for this evening is the lovely Cathy Lort-Phillips. Cathy is the Data Officer for Tropical Public Health. Please welcome Cathy.
Good evening, everyone. I'm Cathy Lort-Phillips, and I'm the Data Officer with Tropical Public Health Services here in Cairns. So I'll just put my... Where is it, Rom? Where is it? Where is it? Help me. Okay, so... So last year there was quite a few changes, in fact big changes to the ACWY register, and from a childhood immunisation register it became a whole of life database, and with that many changes. So in the past I've focused a lot on VIVAS and how the data used to have to go through VIVAS to get to air, or through GP practices were using software. The data would be transmitted through a central mailbox. I'm going to focus a little bit more on air tonight and the changes that have happened to the database and what's important for you guys and how you're going to work forward in getting your data onto air. Okay. So the changes to air are the topics, what air records and how to report your data, finding a person's immunisation history, and Queensland health service providers that are currently using VIVAS and the data transmission of that, and the relationship between AIR and VIVAS. So I know that you're all aware that ACWY in 2016 became a whole-of-life database, so it's now called the Australian Immunisation Register. And there are two phases. So the first phase of change is currently still happening. Every single person that is registered in Australia with a Medicare card is now on air. So you'll all be on the air register. And that's regardless of age. New schedules and the new non-standard vaccines were added. And the next phase, which will be from July 2017 to 2018, June, the adult due and overdue rules will come into effect. Zostavax, the due at 70 and overdue at 70 plus 1 month. And Pneumovax 23, due at 65 and overdue 65 plus 1 month. So basically, what does AIR record and how do you record your data? Basically, AIR is recording everything. So any vaccine that is administered in your practice has to be recorded and reported to AIR. So now's really the time that you all have to consider how are you going to get that data onto AIR. And I'll go through all the different means of doing that. So the ages, the school immunisation data program is the only data that they won't be recording at this stage. We don't know whether this is going to be a permanent thing or not, but it just makes it a little bit messy. So at the moment, if you're requiring any information on school immunisation data, you will still need to contact VIVAS to get that information. Unless the child has been caught up through a GP practice, of course that data will go on. It's not that AIR won't record the data, but generally it's not looking for that data at all. So how is your data reported, transmitted and reported? Basically, in GP land, you're all using software that will be reporting your data directly to the AIR, and that information is shared with VIVAS. If you're in a Queensland health facility, vaccination record forms seem to be still being used, and that is fine. I just say just continue to do so. Fill out your VIVAS forms, fax or email them to VIVAS, and AIR will get that information. The other way as well is to record your data directly onto AIR. You should all be accessing the AIR register by now. I think last year there was a very big push on getting all service providers to use AIR. I'll go through a little bit of that and how, if I can help you to do that, I certainly have information in the front for you. And then, of course, there's the other way you can do is to record that data directly onto AIR yourself, or you can manually fill out a form, which AIR do have on their database, and you can actually fax that in directly to AIR. So finding a person's immunisation history, as you all know, we live up in Queensland, in North Queensland, quite a transient population. You often have people coming into your practice and they've never been immunised at your surgery or your health centre, and sometimes it's really difficult to find that information. So all the more reason to now actually be accessing the AIR website in your own practice. Of course, you can still call VIVAS, and we certainly encourage you to do so, certainly for the school program and Indigenous adult data, which incidentally has not been, the historical data has not been entered onto AIR and won't be. So VIVAS still plays a very big part in getting that information. And the HPV register is another database that you can actually access online and look up a record. So all service providers should now be accessing AIR, and if you're not already registered with AIR, I'll certainly help you show you the steps as to how to do that. Online you can do that, and also then I'll show you how you can actually look up a person's record on AIR. So, I don't know if you can see that, probably very, very small. So basically, there are information sheets out the front which actually give you the link for the website to how to register for access to AIR. And it's quite a simple process. Basically, all here you would be doing is putting in your registration number, your provider number, which is your AIR provider number. For Queensland Health facilities, you probably have a queue number. GP practices usually have a number ending in 2 letters at the end. Then you create your own password, put it in there, and it tells you it's got to consist of 8 alphanumeric characters. You verify your password, put your email address in there, and fax number or STD code. Basically let them know that you probably want them to send you an email with when the reports have been produced and request access. And it's that simple. And you send that off to AIR, and shortly after that you'll get your login details, your password, and your authentication number. And that's all you need to have in order to access records on AIR. And I'm sure once you have that, you'll realise how handy it is, particularly, outside hours when we're not there to help you, and also if you need to do a record encounter for a person. So, this is just to show you how to search for records on AIR. So basically there are 3, probably the most effective ways, and that is to use the 10-digit Medicare number with the reference number on the end. So basically, oh, sorry, what have I done there? Where was I? Okay. All right. So that's all you have to do is you put the Medicare number in with the individual's reference number, and then you just go to identify individual, and that'll bring up that person's record. The second way you can do it is to use the Medicare number without the reference number if you don't have it, and then you just put the date of birth of the child or the individual in there and identify individual, and you'll get that person's record come up. And then the third way, which is effective, but you have to be completely specific and the names have to be spelled completely right. You can put the surname in, the first name in, and the date of birth in, and you'll be able to get the individual's record. If the name is spelt differently or incorrectly, you will not be able to get that record. So it's always a good idea to try and get the Medicare number, and certainly with the reference number on the end of the Medicare number. So this is just a little diagram of how you get the immunisation history up for the individual, or to see what is due or overdue for this person. So, for example, over here, you've got, it's a bit small, I don't know if you can see that. These are the due details, and it tells you exactly what vaccine they're due for, what dose it is, and the due date. And that way you can see whether they are overdue or not. And below you've got the immunisation history. So these are just fields that you can expand. It's actually quite user-friendly. It's not very difficult at all. And this will just give you all their immunisation history. You won't be able to see who actually gave the immunisation, but you can certainly see whether it was a medical practitioner, a GP, or in this case, this was a public hospital. Or they don't identify batch numbers on AIR, but basically you'll have the vaccine, the dose number, and the date that they were given. So it's not very difficult once you've done it a few times. It's really quite user friendly. It's a little bit limiting with your search engines though. In order to get a record, you really do have to have the correct details of the individual. So those service providers that are Queensland Health facilities and are using VIVAS, quite a few of you I know already are using VIVAS for a read-only just to look up records. It's just very, very important that you don't rely on the one database. Very important that you rely on both and that you look up AIR as well as VIVAS. As Romany mentioned earlier, last year was a big push for the no jab, no pay, and they had to get so much data onto both VIVAS, both AIR. The priority was to get the data onto AIR. So we can't be, I just don't believe that either register is fully reliable at the moment. They're working very, very hard, obviously, to rectify that. So sending in your data on the vaccination record forms, also very important that they are filled in correctly. And I would suggest that you still continue to do that and send them into VIVAS. So nothing really has changed in that respect. But I would like to just explain the relationship between VIVAS and AIR and how the data is shared. So VIVAS, all the data that is sent to VIVAS is entered manually, and that data is then sent to a central mailbox right here, which is shared between VIVAS and AIR. So AIR will extract from now that it's become a whole-of-life database, it's going to extract all that data, everything will be going on to AIR. In GP land, you're using software and you're transmitting your data electronically. So it's more important than ever now to make sure that your whole-of-life data tick box is ticked so that all data is transmitted for all ages. And your data is transmitted into that central mailbox, which VIVAS will take what it needs and AIR will take what it needs. So basically, VIVAS is still, a few years ago we stopped recording flu and certain vaccines. So nothing has really changed there. If you're still transmitting your data through VIVAS, that's fine, continue to do so. But the most important thing to know is that AIR is requiring every single vaccine. So whether it's privately funded, whether it's, privately purchased or funded, AIR requires all that data. So the other way you can be entering your data is to do it directly. You can do a record encounter directly onto AIR. And that data you won't be able to see it straight away, but within 24 hours, anybody looking up that record will be able to see that data on AIR. So that's a record encounter. I'm not going to go into details about how to do that today, but it's a very, very simple process. And I'm happy to help anybody if you want to give me a call about that. And then the other way is to fill out a record encounter form, which is obviously a manual form. You fill it out and you fax it off to AIR, and that data will be on AIR within 48 hours. So I've got some handouts in the front there, which will have that website, the link for that registration to get access to AIR, and the steps of how you go about doing it, and also all the steps of finding a record on AIR, and what else I've got out there. Yeah, that's about it, really. So that's it. So I've just kept it very